Yeah, that's all come up, Jack.
Brilliant. Excellent. Yeah, thanks very much, Chloe, and yeah, everyone for organising the event this evening, and for everyone who's attending. It's always nice to be given the opportunity to present and share some of the work that we do in research, and hopefully it's got some applicability and relevance for those of you who are working in clinical practice. So, just to give a bit of context before we get into the presentation about my own background. And I suppose the purpose of this is really just to highlight my own experiences. And I guess everyone's got, their own background where they're coming from in terms of their education and clinical experience, maybe some research or further learning. So for me, my journey kind of in this broad area of musculoskeletal health started 18 years ago now, which is a little bit scary to say, but I did my undergraduate degree back in Australia in Melbourne in human movement, which you can probably tell how long ago it was because back then that's what we called sports science degrees, but it was called human movement back then. And I did my master's of clinical exercise physiology after that. For most of you, probably based in the UK, you may or may not be familiar. We have a clinical profession in Australia, an allied health profession called exercise physiology, which sits alongside physiotherapy, occupational therapy, chiropractic as an allied health discipline. And it's primarily for using exercise as a modality of assessment and intervention for both chronic disease, but also musculoskeletal health. And that was the area that I was always most interested in. And that's the area that I worked in clinical practice for a number of years after graduating in a private physiotherapy clinic in Melbourne. But then I kind of just made the decision about 10 years ago to get back into academia, and I undertook a PhD with the Hamstring Injury Research Group at the Australian Catholic University in Melbourne. And a lot of the work I'm going to talk about tonight in terms of pain and exercise progression was done as part of that PhD program, but it's work that we've continued to follow up on and also then implement in clinical practice. After completing my PhD, I was fortunate enough to go into an academic role at ACU in Melbourne and also helped to form the Sprint Research Centre there. And then 3 years ago, made the decision to relocate over to this part of the world, largely influenced by my better half, who's originally from Dublin, and we met in Melbourne and made the decision to move over here. But that also coincided with taking on a position at a university in Ireland called Maynooth University, who was starting a brand new department of sports science and nutrition. So I'm the deputy head of that department and an assistant professor in anatomy and sports injuries over here. So I've been based here for the last few years and continue to do research and a small bit of consultancy again in that area of sports injuries and primarily hamstring injury rehabilitation. And so obviously, as my accent probably doesn't suggest, I'm not located too far away. I'm just over here. Maynooth is, for those of you who aren't familiar with your Irish geography, it's about 25 kilometres west of Dublin city centre. So it's as good as being in Dublin, but not being in Dublin. So it's a lovely little university town. And as I mentioned, we've just started a whole new department of sports science and nutrition here. And, we'll be potentially looking to grow into other sort of health science disciplines. So, something you might hear a bit more of in the years to come. But I think I've also been living in Ireland long enough now that I can claim some bragging rights over the English. So I'm assuming there's a few English people on the call tonight, so couldn't resist the opportunity to celebrate the fact that Ireland had a win in the rugby over the weekend. But as I mentioned before, I'm going to go back to kind of a period of time when I was working in Australia and part of the Sprint research group. And these three guys here just wanted to make special mention. At the top there, you've got Professor David Opar, who was my PhD supervisor, and then a couple of guys who I did my PhD at a similar time, Narav Mania and Ryan Timmons. So these guys I still collaborate with really closely, but also their work was really influential throughout my PhD. And, a lot of the research that I present tonight, they were instrumental in contributing to that. So always really important, I think, just to acknowledge those guys and their contributions. But really, as I said, a lot of the stuff that I'll talk about in this evening's presentation will relate to the PhD thesis and some of the work that I did. And as you can see by the title of the thesis, objective assessment tools and exercise specific progression criteria during pain threshold rehabilitation. So, like all PhD theses, it's a bit of a mouthful, but really what we were looking at is how do we objectively monitor hamstring function and how do we progress exercise, maybe challenging some conventional practices around pain. The other reason I like showing the front cover of my PhD thesis is to highlight that I'm certainly not immune to making mistakes. And I actually put a big fat spelling mistake on the front cover of my PhD thesis. So it's also just to highlight that everything I present tonight, it's not necessarily going to be perfect, but hopefully there's some stuff you can take away. Okay, so to start off, I think it's important to just have a bit of background about hamstring injuries and some of the variables that we know influence our risk of a hamstring injury from occurring. And some of this work was done as part of the hamstring injury group in Australia in probably about 10 years ago now. This is my colleague Ryan Timmins performing an ultrasound scan on an athlete of their biceps femoris long head. So what Ryan is doing there is using basic B mode ultrasound to take a two-dimensional image of the biceps fem long head. And if we zoom in and take a look at that image, Ryan can perform some analysis using a trigonometric equation to get an estimate of the length of the fascicles within the biceps femoris long head muscle. So this was the major kind of area of research that Ryan undertook as part of his PhD. And it was some really influential work because firstly, he established this technique as being reliable in athletes and being able to measure these muscle architecture variables. But more importantly, he established an association between muscle architecture and hamstring injury risk. So I'll just explain this figure, what you're seeing on the left here. What you have on the y-axis is the probability of sustaining a future hamstring muscle injury. And this is data collected in the Australian elite soccer competition, the A-League, back in about 2014, 2015. And you've got the probability of hamstring injury at the top, one being absolute certainty, zero being no chance of getting a hamstring injury. And then on the x-axis, you've got biceps femoris long head fascicle length. And so what you see here is comparing athletes with a history of hamstring injury in the white and also no history of hamstring injury in the black. And we see there's a difference whereby people with a history of hamstring injury, first and foremost, have a greater risk of future injury, which is probably no great surprise. But also, as their fascicle length increases, the risk associated with having a previous injury actually comes down. And so what Ryan's work showed is that by increasing your fascicle length within your hamstring muscle, you can reduce your risk of hamstring injury, either if you don't have a history of injury or even in those with a previous history of hamstring injury. So this was some fairly impactful work. And one of the other kind of modifiable variables that Ryan looked at was strength of the hamstring muscles, measured using the Nordic hamstring exercise device, or now commercially known as the NORD board. And so we're measuring eccentric knee flexion strength during the Nordic hamstring exercise. And in that same study, Ryan showed a very similar relationship between getting stronger or being stronger and having a lower risk of future hamstring injury. So based on this data here, we can basically summarize and say that if you have short fascicles within your biceps femoris long head muscle, being the most commonly injured hamstring, and if you have lower levels of eccentric hamstring strength, your risk of a future hamstring injury is significantly increased. So this is something that we should consider not only from an injury prevention standpoint, but also in terms of rehabilitation. Because if we think about the context of having a hamstring injury and then rehabilitation, the ultimate goal is to get the athlete back to play as quickly and safely as possible. And so that's a really simplified look at hamstring injuries. We go from the point of injury, we want to get them back to play. And in the middle here, we're going to do some rehab. Now, what rehab is always going to be variable depending on the individual, but there's some certain things that are fairly common across the board when we prescribe rehabilitation for a hamstring injury? Probably first and foremost, two of the most common interventions in most running-based sports where hamstring injuries are common is going to be progressive exposure to running and running at progressively higher speeds, getting back towards, say, sprinting for a football player, rugby player, of the like, and also doing some form of eccentric loading for the hamstrings to prepare them for those physical demands of the sport. Now, supplementary to that, we might also include some other modalities such as passive treatments or flexibility type exercises. And then we might also work around the hamstring and try to improve perhaps our lumbo-pelvic control or maybe sprinting mechanics. These are things that are often included in a hamstring injury rehab program. We're going to focus this evening on this central role of progressive running and eccentric loading. And that's not to say that those other modalities aren't important in the context of hamstring injury rehab, but it's fair to say that these two modalities of training are probably the hardest to understand when to introduce them following an acute muscle injury, because there's a perception that following an acute injury, we need to avoid loading the injured muscle and we need to avoid length and eccentric contractions. But we're going to challenge that a little bit this evening with some of the research that we've done kind of over the last 10 years. So having a look at this model of hamstring injury rehabilitation here, at the start of my PhD research, one thing that we looked at was, well, what does the current evidence say in terms of when is it okay to progress rehabilitation as far as running and hamstring strength exercises? So what we did was a systematic review of the published literature at the time, and this was back in about 2015, 2016, so it's about 10 years old now. But at the time, what we found is that published rehabilitation protocols are largely based around the alleviation of pain, meaning that progression of exercises and running and rehabilitation is typically only allowed within pain-free limits, meaning only move on when the athlete or the patient is reporting absolutely no pain, and then we deem it safe to progress that intervention. We went and looked at the literature related to that, and we sort of thought, well, although that makes logical sense, there could be some potential issues that a lot of this research isn't actually based, or a lot of these recommendations aren't necessarily based on empirical evidence that you actually need to be pain-free in rehabilitation. One of the potential problems with always trying to be pain-free following an acute muscle injury is it potentially is going to delay the introduction of key stimulus for adaptation and training, such as running and eccentric loading. And in the context of a hamstring injury, particularly in sport where there's pressure on athletes, particularly at the higher levels of competition, but even your weekend warriors, they always want to get back and participate and train and play as quickly as possible. And so there's pressure to accelerate return to play. And the problem with that is if we've got a pain-free approach delaying the start of effective rehabilitation strategies, and we're accelerating the time that we return to play, we've got a very small window of time where we can actually give the athlete some exposure to adequate rehabilitation stimulus. The problem with that is if we then come back to where we started in terms of these risk factors, so looking at biceps femoris long head fascicles and eccentric hamstring strength, if those things are impaired prior to the injury occurring or maybe contributed to the original injury occurring, they're not going to be adequately addressed in rehabilitation. And that's going to leave our athletes at risk of re-injury after they return to play. And so we sort of developed this model and thought, well, there's a potential problem with avoiding pain in rehab because we're possibly underloading or leading to suboptimal loading throughout a rehabilitation window of 2 to 3 weeks. And therefore, we're returning athletes to play in a state where their risk of re-injury may be high. So the next step in the process that we thought, well, how can we short circuit this? How can we maybe accelerate the introduction of rehabilitation stimulus following an acute hamstring injury? And the approach that we took was to design a randomized controlled trial where we wanted to challenge the conventions of remaining pain-free and take individuals with an acute hamstring injury and randomly allocate them to either a pain-free or what we called a pain threshold approach to hamstring injury rehabilitation. You can see here down in the bottom left the eligibility criteria for this particular study. So it was open to men and women, although when we ran this study, we actually only had male participants who actively engaged and came along and participated in the study. So all our participants were male. They had to have acute onset posterior thigh pain with a clear hamstring injury mechanism, and they had to present for an initial clinical assessment to have that injury diagnosis confirmed within 7 days of injury. Then they had to have pain with palpation of the injured muscle and pain with contraction of the muscle. So basic clinical diagnosis of a hamstring strain that many of you would use in your own clinical practice. Fortunately, because we were in the university environment, we were also able to take some other outcome measures. And so we had Brian, who was able to measure the muscle architecture of each athlete in this particular study or participant in this particular study. And so he took those 2D images and we got that estimate of biceps femoris long head fascicle length. We took basic clinical measures of range of motion every time the athlete came in for a rehabilitation session. And we also measured isometric strength using a wired load cell in two different positions. So you can see here a participant lying supine with their hip and knee at 0 degrees of flexion, and then here in an outer range position of 90 degrees of hip and knee flexion. So this was done every single time, not just in the initial consultation, but every rehabilitation session that they came in, which was twice a week until they met return to play clearance criteria. So I should also mention that was the same with the muscle architecture measurements. They were taken at the start of each of these particular sessions. So what the study design actually looked like is we assessed or we screened 52 participants for eligibility, and there was 43 who met our eligibility criteria, and then they were randomly allocated to either the pain-free group, whereby when they performed rehabilitation exercises, which was supervised by myself, they were only allowed to continue with that exercise if on a 0 to 10 scale, they said they had zero pain or no pain whatsoever. If they reported 1, 2, 3, or any other number on that scale, we would modify the exercise and make it easier until they reported no pain. In contrast, those that were randomly allocated to what we called the pain threshold group, these guys were allowed to continue exercising if they reported no pain or up to 4 out of 10. And so, in effect, they were given a slightly more aggressive approach, but still, if they reported 5 or above, we would then modify the exercise accordingly. Apart from the difference in these pain scales, the rehabilitation that both groups received was completely identical. So they performed the same exercises, the same running program twice per week until they met return to play clearance criteria. So we'll go through what the rehab program actually looked like now. And so firstly, we had a progressive running protocol. And this was a fairly basic 9-stage running protocol where you can see here in this table, we had an acceleration phase, a hold phase, a deceleration phase of varying distances. And from stage 1, 2, and 3, we're working from a walk to a jog. So walking through the acceleration, getting up to a slow jog, and then going back to a walk again. And so basically we defined a jog as being anything up to 50% of their perceived max running intensity. So that was the first 3 stages of the running program. Then stages 4, 5, and 6, we then worked in this zone here where they progressed from a jog to a run and then back to a jog, whereby a run is defined as anything between 50 to 70% of max speed. And then once we get towards the later stages of this running protocol, we had high speed running in stage 7 and 8, where people were building up to a high speed between 70 to 90% of their max, and the final stage where they had to be able to sprint. And so both groups of participants in this study progressed through this running protocol, and they did these running sessions after they'd done the sort of clinical tests each time they came in for rehabilitation. And again, the only difference between the two groups was the level of pain that was permitted during the performance of this running. Once they performed the running in each session, again, that these were twice weekly training sessions that they came in for. They also were exposed to some exercise progressions in the gym, and all of these exercises were built around hamstring loading, with a bit of an emphasis on eccentric loading because we wanted to try and drive changes in both strength and fascicle length or muscle architecture that we talked about earlier. So again, this program was the same for both groups, the only difference being the pain limits allowed. The exercises in this program, they all started out performing bilateral variations of exercises in their first session. So they did a bilateral hamstring bridge aiming for 10 to 12 repetitions for 3 sets per session, a 45-degree hip extension or a hip hinge type exercise, again, starting off bilaterally from their first session and performing 8 to 10 repetitions, and a submaximal eccentric exercise called a bilateral hamstring slider. So you can see in the video here, looks like a standard glute bridge, heel on sliders, they extend away and then drop down. So they're just performing that eccentric phase under tension. Now, the key thing with this rehab program or this exercise program here is every individual was able to progress these exercises once they could perform the prescribed repetition range within their group's prescribed pain limits. So if you were in the pain-free group and in the first session, you could do this double leg slide out for 6 to 7 repetitions, you were then exposed to the next progressions, which were the Nordic hamstring exercise or the unilateral slide out exercise. Likewise, in the pain threshold group, you were able to progress provided that your pain level was 4 or less. So those progressions of the hamstring bridge were to a single leg variation. For the 45-degree hip extension, similarly, it was progressed to a single leg variation. And then there was also the addition of load held at the chest in 5-kilo increments once they could tolerate single leg body weight. And as I touched on before, the progression points from the bilateral slide out were introducing the Nordic hamstring exercise, being a more maximal eccentric knee flexion movement, and a unilateral variation of the eccentric slide out exercise. So this was the rehab program that both groups performed. And again, just really important to reiterate that the only difference was the level of pain that was permitted during these exercises. So let's cut to the chase and have a look at what we actually found in this particular study. The primary outcome measure of interest, as it would be in any kind of injury or acute muscle injury study, is how long did it take the athletes to return to play, or in our case, we use the outcome measure of achieving return to play clearance. And the reason we did that is we had athletes of different competitive levels from different sports. So it wasn't really appropriate to use an actual return to sport time, but instead, once people met these criteria, so once they had no pain on palpation of the injured muscle, no pain during range of motion testing and relatively normal between limb symmetry, no pain during maximal isometric contractions of the hamstring, and most importantly, once they could sprint maximally without pain or apprehension. And again, it was probably important to note here that even those in the pain threshold group, they had to meet these pain-free requirements before being allowed to return to their chosen sport. So that was consistent across both groups. What we see here in this figure on the y-axis, you've got the number of days from acute hamstring injury until return to play clearance was met. And on the left, you'll see the pain-free group, and on the right, you'll see the pain threshold group. So this figure just shows the individual data points and then the group average. And you don't need to know too much about statistics to see that there's a clear overlap between those two groups. And when we ran statistical analysis on this, no surprise, there was no statistically significant difference in terms of return to play times between the pain-free group and the pain threshold group. So in short, pain threshold rehabilitation didn't accelerate the time that it took to meet return to play clearance. And I'll come back to that point in just a moment. The other outcome measure, primary outcome of interest, was the number of re-injuries that occurred in the 6 months following meeting return to play clearance. And again, there was no difference between the two groups here. There was two participants in the pain-free group and two participants in the pain threshold group who suffered a recurrence of their hamstring injury within the 6 months following return to play clearance. But overall, that's a re-injury rate of about 10%, which is relatively low compared to some of the other published literature out there on re-injury rates. One probably just side note here to take a look at is if you look at those re-injuries, three of the four re-injuries occurred in participants who met return to play clearance in less than 14 days, meaning they had a pretty quick and a pretty short rehabilitation. And so a key learning from this was that although they met criteria to return to play, those criteria were fairly basic and fairly easy to pass, and it didn't consider natural healing timeframes. And so the relative rate of re-injury was higher in those that were cleared within 2 weeks compared to those that had longer in rehabilitation. So I think it's important that although we always push for an objective criteria-based approach to rehabilitation and return to play decision making, this data suggests that we still need to respect natural healing timeframes. Let's come back to the main purpose of the study and comparing pain-free rehab and pain threshold rehab. One of the interesting things is because there was no difference in rehabilitation duration, that allowed us to make greater comparisons of objective measures of function, given that the exposure to rehab was the exact same as far as the duration of rehabilitation in both groups. However, the exposure within sessions to certain exercises may have been different because if you're in the pain threshold group, it's more likely that we're going to progress from, say, a double leg to a single leg exercise or run at a higher intensity. So even though it didn't get you back to play any quicker, did it lead to any change in adaptation between the two groups? And so we're going to start by having a bit of a look here at changes in biceps femoris long head fascicle length. So that measure of our muscle architecture, remembering back to the start that having longer fascicles is beneficial and reduces our risk of injury. So here you've got fascicle length on the y-axis in this two-panel plot. And on the x-axis, you've got the initial clinical assessment before they started rehabilitation, return to play clearance, and we also got all participants to come back at 2 months following return to play clearance for a follow-up assessment. This horizontal dotted line here is just a point of reference from some published research that suggests that those who have fascicles of less than 10.56 centimeters tend to be at an increased risk of injury. Doesn't mean that if you're below that, you will get injured, and above that, you won't get injured, but your relative risk of future injury is significantly different above and below these cut points. So here you have the results, firstly, of the pain-free group. So you see at the start of rehab, and this is in their injured biceps femoris long head, you can see how their fascicle length on average is down at about 9.5 centimeters. At the time of return to play clearance, you can see that there's been a big increase in their fascicle length. So now they're up to just over 11 centimeters. But at 2 month follow-up, the average had dropped back down to about 10 centimeters. So there was a bit of a detraining effect in the pain-free group. If we compare that to the pain threshold group, we see a larger change in fascicle length from the initial assessment through to return to play clearance. And perhaps more importantly, that change was maintained better in the pain threshold group, meaning the increase in fascicle length was perhaps a bit more sustainable because there was greater exposure to rehab stimulus in those that had a slightly more aggressive approach to rehabilitation. And we can also then look at hamstring strength, remembering that we objectively measured knee flexor strength in two positions, but we're going to look here at the outer range 90-degree hip and knee flexion test here. And so what you've got on the y-axis is relative to the contralateral uninjured limb, the strength of the injured limb expressed in percentage terms. So where that horizontal red line is represents absolute symmetry, so 100% or equal between injured and uninjured limbs. So firstly, let's have a look at the results in the pain-free group. So no surprise that at the initial assessment, there's significant impairment in strength from the injured compared to the uninjured limb for most participants. Now, while on average the group improved, there's still a very large spread of data at return to play clearance, with quite a number of participants being less than 90% of their contralateral uninjured limb. And at return to play clearance, the average being below 90%. If we compare that to the pain threshold group, what we saw there was a greater increase in strength from initial clinical assessment through to return to play clearance, and then a better maintenance of that strength at the 2 month follow up. So, long story short, what does this all mean? Well, if we come back to our initial model of hamstring injury rehabilitation, and perhaps we substitute that pain-free approach for more of a pain threshold approach, what we're seeing is that although return to play clearance is no different, we are seeing greater improvements in our fascicle length and our hamstring strength in a relatively short rehabilitation window. And in both groups, that led to a relatively low risk of subsequent re-injury of around about 10%. So it's not perfect by any stretch, but we'd like to think that it's perhaps a bit of an improvement on more conservative approaches to hamstring injury rehabilitation. Now, we then did a bit of follow-up work to kind of investigate, well, regardless of if people were in the pain-free or the pain threshold group, we sort of reflected and thought a bit more about our gym-based exercises in this program. And what we noticed as we were doing this particular study is that we were exposing people to exercises, particularly eccentric exercises, as highlighted here. So, like your bilateral slide out, the Nordic hamstring exercise, and a single leg eccentric hamstring slider. We noticed when running these rehab sessions that people were able to tolerate these exercises much earlier than what I would have previously prescribed in my own clinical practice. And when speaking to many clinicians around the place, they were also surprised at how early these people were able to tolerate these particular exercises. And we figured that even if you were in the pain-free group, you were still progressed, but as soon as you could perform the sub-maximal version of these exercises within the prescribed rep range. They weren't held up artificially by some time frame. It was completely individualized based on their tolerance to an exercise-specific progression criteria. And so we took a closer look at this specific progression milestone where we talked about the introduction of high intensity eccentric hamstring exercise, being a Nordic hamstring lower and a unilateral eccentric slide out. And we did this in a follow-up study where we analyzed the data from our original randomized control trial. And what we were really investigating here was this exercise-specific progression criteria, whereby as soon as participants could perform this bilateral slide out exercise, they were progressed onto performing the Nordic hamstring curl or the unilateral eccentric exercise. Now, it's important to note in this particular study, we pulled the data from both the pain-free and the pain threshold group together because they both followed this progression criteria, with the only difference being the amount of discomfort that was allowed. And what we found is when we pulled the data from those 43 participants together, what we get here on this particular plot, we're going to be looking at the percentage of those 43 participants on the y-axis, 100% being all of them, 0 being none of them. And on the x-axis, you've got the number of days following hamstring injury. And what we're going to show you here is what we call a step plot, where it basically shows you the cumulative proportion of participants who achieved the introduction of high intensity loading, meaning they were able to perform the Nordic hamstring exercise or single leg slide out relative to the number of days following injury. So what you can see here is that by about 5 days following acute hamstring injury, approximately half of our participants in our study were already performing the Nordic hamstring exercise, a single leg eccentric slide out, which prior to doing this study, most people would have recommended that those sorts of exercises be avoided for the first week to 2 weeks following an acute muscle injury. Whereas we found that by using this exercise specific progression criteria, they were able to tolerate it relatively early. So on average, it was 5 days following acute muscle injury. What we then compared this to was what is conventionally recommended in terms of progression of eccentric exercises. And going back to our original systematic review of the literature, what we found is that quite often being pain-free on an isometric hamstring contraction is used as a kind of gatekeeper to then introduce eccentric exercise. And this goes back to your classic animal model studies and classic muscle injury models where we recommend we start with isometric loading, we then progress to submaximal concentric loading before introducing eccentric loading. That's a little different to our approach, where we went a submaximal eccentric from the word go and progressed to a maximal eccentric as soon as that could be tolerated. And so what we did is we then looked, well, we actually measured their isometric strength and we asked them about their pain with an isometric contraction every time they came in to do a rehab session. So we figured, well, we can now go back and analyze that data and actually see, well, how long did it take for people in this study to actually be pain-free on an isometric contraction compared to when they actually were introduced to these high-intensity eccentric loading. Now, before I show you the time that it took, what we're going to see here on the left-hand panel is our two isometric strength tests. So 0 degrees hip and knee flexion here on the left and 90 degrees hip and knee flexion on the right. And we're firstly then going to see the injured leg relative to the uninjured leg in terms of peak force. So as a percentage of injured relative to uninjured. And all the black data points are going to be those that are still reporting pain during this test. The white data points are not reporting pain. So I'll put both of the plots up here. And the thing to understand about this data is this is the isometric strength test on the exact same day that these participants were first introduced to eccentric exercise. So in other words, if you have a look at this figure here, you can see that the vast majority of data points are black. What that means is on that particular day, all those black data points were reporting some level of pain during an isometric strength test, which if we were to adhere to standard rehabilitation progression, we wouldn't have exposed our participants to any form of eccentric loading. Similarly, we also see that almost all of the data points here are below 90%, meaning that they had a relative asymmetry or deficit in their strength as well, which is also often used as a guideline or a progression criteria to start doing eccentric exercise following a muscle injury. Now, again, we found that despite having significant deficits in strength and reporting pain during those strength tests, on that same day, our patients or athletes were still able to tolerate the Nordic hamstring exercise, a single leg eccentric slide out, so relatively high intensity eccentric loading without any issues. Now, how long did it then take these particular participants to be pain-free on an isometric contraction? Well, you can see here by this step plot that the average number of days to be pain-free on an isometric was 11. Now, in the context of most injuries, you'd look at that and think, well, what's really the difference between 5 days and 11 days? If I just wait one more week, is it really going to matter that I delay the introduction of eccentric loading by maybe 6 days longer? Well, the problem with that in the context of hamstring muscle injuries, and in our study, probably relatively low-grade hamstring injuries, where the average return to play time or return to play clearance completion of rehabilitation was 15 days. The problem with that is if we use the conventional approach and we only introduced eccentric stimulus at day 11 on average, that's a very short window of time to give exposure to progressive eccentric loading. It's probably only going to be 1, maybe 2 rehab sessions at best, compared to the way that we introduced eccentric exercise, which on average was 5 days, which gives you more time to not only introduce those exercises, but progress them adequately to drive stimulus for adaptation. And to kind of finish off and have a look, well, overall, what did we see in terms of adaptations that relate to injury risk? So we'll come back to where we started at looking at muscle architecture firstly. So again, the y-axis here, you've got fascicle length of the injured biceps femoris long head. And again, for reference, here's a horizontal line at that statistical cut point for injury risk of 10.5 centimeters. On the x-axis, we have eccentric knee flexion strength measured by the Nordboard device. And again, we can plot a vertical line intersecting the x-axis at the cut point for injury risk taken from some of Ryan's PhD work. Again, you don't need to understand statistics to have a look visually at this graph to appreciate that it gives us 4 quadrants, whereby in the bottom left, we're relatively short in terms of our fascicle length, and we're relatively weak in terms of our eccentric knee flexion strength. The top right corner is where we want our athletes to be. We want them to have relatively long fascicles, but we also want them to be strong. So there's an interaction between those risk factors. Now, if we have a look at all 43 participants in our randomized control trial, on the first day that they started doing eccentric loading, remember that that was an average of 5 days following an acute muscle injury. This was where they sat in terms of their level of eccentric strength measured on the Nordboard device when they first did a Nordic lower, and their fascicle length on the y-axis. You can see that by far and away, all of the participants, or the majority of the participants, were in this short and weak quadrant, where we'd assume there's probably a heightened risk of a hamstring muscle strain injury. Now, by introducing eccentric exercise on that day and gradually progressing until they met return to play clearance, on the final session of rehab, this is where they sat. And so you can see it's almost a mirror image moving from start of rehab to end of rehab, where we're taking the majority of athletes from being short and weak and progressing them to being long and strong just by using a fairly basic exercise specific approach to progressing rehabilitation rather than arbitrarily holding people back based on some kind of independent test like an isometric contraction or based on their level of pain. And so not only do we see that having a pain threshold approach to rehab might give you some small advantages in terms of fascicle length and strength, but more importantly, if we use an exercise specific approach, we can get that earlier introduction of progressive running speeds, eccentric loading in our rehabilitation. And we'd like to think that that has some influence on reducing re-injury risk following return to play. Now, I'm going to stop talking for a little bit there because I'm sure there might be a few questions, and I know you probably don't want to listen to my boring Australian accent for too long. So I'm more than happy to hand it over for a few questions. I do have a couple of additional slides just on some recent work that we published that may or may not be of interest to people. But perhaps to start, I'm happy to throw it open to some questions, and we can go from there.
Hi, Jack. Thank you so much. I think Chloe is having some issues with her mic, so I will take over a little bit, and then we can kind of go through a couple of Q&As. So there is a couple of questions that have come up, and I suppose from your talk, we would gather that early eccentric training, sorry, is better than your usual passive stretching for fascicle length at this stage for hamstrings?
Yeah, so
Yeah.
the evidence in terms of how to actually adapt fascicle length and get improvements in that particular variable, the most potent stimulus is eccentric loading, and particularly that higher intensity eccentric loading. So in healthy individuals, in uninjured muscles, it tends to be a relatively high intensity contraction that helps to drive those changes. There are some studies in other muscle groups that suggest you can get some changes in muscle architecture through stretching. But the challenge with that is with passive stretching, particularly acutely following injury, that's actually often causes pain and is often contraindicated. So we found it quite interesting that there's something unique about eccentric contractions through exercise that seem to be fairly well tolerated.
Okay, fab. No, thank you. And just for this as well, for I suppose the participants and how you recruited people in, did you have a, I suppose, um, did you have a grading system on, I suppose, the type of hamstring strains as well with that too? Just a few people have said they might have missed what you've said about that in terms of how you recruited people in the stage and the type and the grading of the hamstring
Yeah,
tears there.
no, it's an excellent question because logically, when we see things like they met return to play clearance in, on average, 15 to 16 days, it's a pretty quick turnaround. It's a
Mhm.
fairly short rehabilitation. So certainly these were on the lower end of the spectrum, but they still had to meet clinical criteria, meaning that they had to have an acute onset of posterior thigh pain. They had to, when they presented for a clinical assessment within 7 days of injury, they had to have pain with localized palpation. They had to have pain with contraction of the muscle, but we didn't have any imaging based criteria because we didn't
Okay.
have access to MRI. So we don't have confirmation of British Athletics muscle injury classification or anything like that in this study, which is a limitation for sure.
Mhm.
Um, that said, one of the reasons I like this particular kind of outcome in this study is for clinicians who don't have access to those things, that's what they're going to be doing in their practice anyway. So there's probably still some unanswered questions in terms of how effective would this approach be in maybe a higher grade hamstring injury that may involve, the tendon or something like that. But I've used this approach with many cases like that with high grade and low grade injuries. And the beauty of that approach, whereby you progress exercises individually, is
Mhm.
it's totally up to their tolerance. And it's not like every single participant was doing those exercises on day 5. We certainly had some participants who, outside of the study, they had an MRI and, they, subsequently showed us results of that. And we know that some of them had high grade injuries and they took a bit longer to reach those milestones. But again, the approach here is that, well, it still caters to that athlete when they're ready, as opposed
Mhm.
to saying, whether it's conservative or aggressive, everyone must start at 5 days or everyone must start at 3 weeks. You're going to have some that take longer, some that are quicker, but it's when you're ready to tolerate it. So I've used this approach, consistently, albeit with maybe variations in specific exercises. But that's how, following any injury with a patient, I would progress and regress is not based on sort of arbitrary timeframes, but actually based on how do they tolerate a sub-maximal version of what I want them to do. And to
Mm.
be honest with you, I don't think it's anything that complicated. I actually think it's a relatively simplistic approach in the way that, if you want to know if you can do something in the gym, we'll do something slightly easier. And then once you can tolerate that, make it a little bit harder. It's really basic principles of exercise progression, regression.
Yeah, and I think it's really good that you've said there about it wasn't based on MRIs because I think an awful lot of us, depended on where we work, some of us might be really lucky and have access through private practice, a direct link to MRIs. But if you work somewhere in the health service where it takes a whole lot longer for what we need to get these athletes back, or whether they're weekend warriors or not, sometimes having that is a barrier trying to wait for an MRI to
Yeah,
come through and slows everything down. I
absolutely.
suppose
Yeah.
for this as well, I've got one of the questions here asking how did you support the patients in the pain threshold group in terms of, I suppose, was extra assurance needed to push through? Was there any sort of cues that you would have gone through? And when it wasn't exactly pain free in terms of, I suppose, patient comfort for that as well?
Yeah, that's a brilliant question. And these are the things that are very difficult to articulate in like a scientific paper format. And,
Yes.
often this is where, for me, having a background as a clinician is where a lot of the really interesting stuff comes out. So I guess a couple of examples of the patients or participants in this particular study, like we had examples of people in the pain threshold group who, just by working with them, you could tell that naturally they'd be more conservative with the way that they
Mhm.
would want to exercise and load. Likewise, in the pain free group, we had some that would naturally be more aggressive. Now, I found really interesting being the person running all these rehab sessions is everyone learnt really, really quickly, typically by their second rehab session, that as soon as they were saying, like, if I was giving them an exercise and during that set, are you having any pain, or at the end of the set, is there any pain? Has that pain dissipated? So being really careful and asking them about those things. If they were someone conservative in the pain threshold group, they learnt pretty quick that as soon as they were saying more than a five, I was regressing the exercise. So they would then kind of gravitate towards that. Likewise, in the pain-free group, if they had their first session where it might have been more conservative because I was always pulling them up and making things easier, if they wanted to push, all of a sudden they just start telling me that it's a 0 out of 10 because they know that that's the trigger to progress onwards. And what I learned from that is that it's less about the actual number of 4 out of 10, 5 out of 10, 3 out of 10. That can give you a bit of a guideline, and I think it's still useful. But in reality, what I do with people now is I ask them to rate their pain. And again, I use that sort of pain threshold approach, give or take around that sort of 4 mark as that sort of cutoff. But the most important question for me is actually, do you feel comfortable to continue? Because you'll get some people who, even when you, and it's super important with any pain scales, I'm sure everyone on this call is pretty familiar with that, you anchor your pain scale. So make sure you explain that. And that was something that we did at the start. We explained really clearly that 0 equates to absolutely no pain, and 10 is the worst pain you can imagine. But even when you provide really clear anchoring, people's perceptions are still different.
Hmm.
And so, we had some really sort of almost funny cases where people would be, even in the clinical assessments where we're asking them about pain, and they'd, you know, contract, and we'd say, oh, how was that? Oh, yeah, not too bad. How about out of 10? Oh, like an 8 out of 10. And I'm like, if to me, 8 out of 10's alarm bells, like, and they're sort of chilled out, whatever. And others that are like wincing and sort of expressing pain and saying, oh, are you okay? And they're like, oh, yeah, it's a bit sore, but it's probably only like a 2. And you're like, okay, well, so those numbers can obviously be a bit skewed. But really what I've learned is that particularly when performing exercises, the athlete themselves is the best judge of whether they're safe to continue or not. In terms of if they
Hmm.
feel comfortable, then you as the clinician has that additional level of expertise to know whether it's appropriate to be advising as to whether it's safe, or do you know what, I need to pull back a bit here. And
Hmm.
so, yeah, that education piece is super important. I didn't go into the presentation this evening, but we did record. We did use a Tampa scale for kinesiophobia in this particular
Excellent.
study to see,
Hmm.
fear of movement. And look, both groups got a reduction in their fear of movement from the start to the end, which, you'd expect following any acute injury, that fear is going to be higher early days and then it's going to drop off. There wasn't any significant differences between the group, but we're probably statistically underpowered for that comparison. Um, but there was, yeah, certainly some cases where even some of those more conservative athletes, by working with them and explaining about um, you know, pain and the fact that it doesn't necessarily equate tissue damage, and that, it appears to be relatively safe, they became more confident. And yeah, like, we, as the researchers and clinicians running the study, were even surprised with how well people were tolerating these progressions. Like within the first few times it happened, I was sort of almost going, geez, well, you've met the criteria to start doing, say, a Nordic, but it's only day 1 following injury in some cases. And I was like, oh, geez, what have I done here? But, we didn't, fortunately, we had no adverse events, and I've never had an adverse event using this approach, because it's still very careful in terms of starting low and progressing. I think some people misinterpret this work as, oh, we just threw everyone in the deep end. In actual fact, we actually start everyone relatively sub-maximal, but then we
Okay.
allow them to progress. Yeah.
Because I think that was one of the questions as well, and we'll go through maybe one or two really quickly. And I suppose it was starting at asking how did you decide in terms of the pain threshold group? I suppose what was the lower number to start at, and then I suppose how soon or how quickly you would have progressed up to the minimal, or sorry, to the maximal. But like you said, it's probably very much participant feedback as to that as well. And
Yep.
you did mention briefly about, I suppose, getting the running program, or getting the straight line running in relatively quickly, which I think links in quite well with the Aspetar protocol that's been out a good while as well.
Yep.
How soon did you bring in that running protocol in parallel
Yep.
with what you guys did.
Yeah, cool. So I'll just start on the first point. And again, I didn't mention it just for purpose of time, but we based the sort of pain threshold model off the pain monitoring model that was, pretty first used, I think, back in 1997 with patellofemoral pain in
Mm,
Scandinavia, and then subsequently with like Achilles tendinopathy. So more from like the chronic overuse type injury world was where that was sort of originally used, and we sort of then picked that up, obviously, in the context of a more acute muscle injury. So the only difference was just the way we sort of simplified the description rather than there being sort of, 0 to 2 safe. I think it's 2 to 5 acceptable. And then above 5 is sort of your danger zone. Like we just simplified it to be anything up to a 4 we're comfortable with, anything
mhm.
above that. So you could argue it's almost the identical model. And certainly we were informed by that work. And as far as the running goes, yeah, so the running was done in every session when they came in. So just to give an example, even in the first visit, when they come in to confirm that they have an injury, they went through those clinical assessments, and as soon as that was confirmed, they got randomly allocated to one of the two groups, and from there, I then took them through the rehab program, and we'd start with the running, and then we'd go into the gym, and so
Fab,
walk to
okay.
jog was that first progression. But the way this program was structured, they could only do up to 9 repetitions, and they had to repeat 3 times before they progressed to the next level. So there were some barriers in terms of the fastest they could possibly run in that first session was only ever up to about 50% of their max. But I actually have no doubt some of them probably could have tolerated slightly faster than that.
That's right, okay.
It's more that once you hit about 60 to 70%, that's where your hamstrings actually start doing work. So running is actually super safe following an acute injury at slow speeds. In quite a lot of participants who actually had pain with walking, they do a really slow jog and they'd report that they felt more comfortable doing a
Okay.
little shuffle run than even normal walking gait, which I found quite interesting.
Mm.
But it's where you have to be really careful is those high speeds, because that's where the hamstrings are actually required to, do their high levels of negative work. So you'll often see really fast progression, maybe within the first week following injury. People might go from only walking or not even walking pain free to jogging really comfortably, or they might even get up to running at 60 to 70% by sort of the day 6, 7 mark. And so logically, they're thinking in their head, well, progression is just going to continue to be linear. So if I've gone from 0% to 70% in 7 days, well, surely by 10 days, I'll be at 100%. But it's a really important education piece there about that above 70%, because the physiological demands or the biomechanical demands on the hamstring really go up exponentially. There's going to be a slower progression to hit those maximal running speeds.
So I suppose in that probably a little bit quicker for an awful lot of people, early doors, and a little bit slower towards the end to get that max really.
Yeah, in terms of the
Yeah.
progression within
Yeah.
sessions, so
Yeah.
I'd be quite loose with like how much I allow people to progress rep to rep within that sort of 50% band. Like their
Mhm.
first run, I might say, okay, just try and jog through at 30% of your max. And they do that. Next rep, go up to 50. No bother, you'll be fine. But when you're hitting like say 70, 80%, I want, multiple repetitions at say 80% before I even then get them to 85%. And then
Yes.
85 to 90. So there's smaller increments. And I think that's a subtlety that's probably, again, hard to capture in just the paper itself. We've published some other work kind of on that and sort of providing some recommendations around running progressions. And certainly that's just some examples. There's plenty of other people who are far better versed in, returning to running and running drills and all the technical side of running, which we really didn't focus on at all. Ours was purely around the exposure to the stimulus. But there's obviously those sides of things with any lower limb injury, thinking about what is the influence of technique, and is there a need to do drills? It's probably somewhat debatable, but there's probably a place
Hmm.
for it.
Brilliant. No, that's great. No, thank you. And I tell you what, I think we're just after 8 o'clock here, so I think we'll hit the finish button on that now. But just to say, look, thank you so much, Jack. That was really good. And I haven't gone into my nerdy hamstrings rehab for a long time, so it was really good to see that again. So thank you. Just as a note to everyone who's been attending this evening, we do have the QR code for the feedback link about tonight's session as well. and it's in the chat box there too. We would really appreciate feedback on this session and what you guys would like us to cover over the next I suppose the next year and the next couple of months. And just to say as well, and it flashed up there too, we have our final 5 speakers confirmed for our upcoming conference in September over in Durham this year, and it's on Saturday the 19th. And again, early bird tickets are available over the next month or so, and we'd really love to see everyone there. So it just leaves me to say thank you to Jack for taking his time on his Tuesday evening to go through his great work with us. And we, like we said at the start, the YouTube video should be up and available for 4 weeks after the talks. If you want to go back and review and recap everything that Jack covered this evening, we can do that. And probably as well, what would be nice, Jack, we might look at sharing some of those papers that you talked about as well. I think that would be really helpful as well for that too. But
Yeah,
no, that
for
leaves
sure.
us to say just thank you so much for everyone, and we'll see you when we see you. Have a good evening.